All right, let's continue with our shoulder evaluation module within our musculoskeletal ultrasound course, and we're talking about position 3. Position 3 for evaluation then, similar to the previous ones, positions 1 and 2. The patient should be comfortably seated, and we will ask them to place their hand on the opposite shoulder to the one we are going to evaluate. And we are going to place our probe in the posterior region. This is a position for evaluating the posterior segment of the shoulder, and the position is as we show here, basically having the patient place their hand on the opposite shoulder. And now we are going to refer to the anatomical segment. So we place our probe in the long axis for the infraspinatus. It's very easy to locate. Basically, we look for the bony structure of the spotting. What is below is the infraspinatus, and what is above is the supraspinatus, which we already discussed earlier. So let's go ahead and start our hour. Placement of the probe in the long axis of the infraspinatus, moving from cephalic to caudal. Afterwards, we will rotate our probe 90 degrees to obtain and visualize the short axis of this muscle segment. The information we're going to obtain is summarized here in this ultrasound image. Basically, then, identification of structures are fundamental anatomical features that we already know how to do. We look for the bone pattern with posterior acoustic shadowing, a hyperechoic image, and by its rounded shape, we already know it's the humeral head with some cartilage content. Here, then we follow the structures that are around it, and notice that the capsule, because it is rich in fibrous tissue, is more hyperechoic. Next comes a triangular structure, as shown here, which is the labrum. Remember that ultrasound is not an exam for evaluating the labrum. Here you can see some lesions when they're in this area, but the study of the labrum is done with an MR arthrogram. We can look at the acoustic window of our joint. So this position allows us to perform interventions and describe the anatomy. So we can see our glenohumeral joint in position. Great. In front of our humerus is the glenoid with its typical shape, within which the ultrasound pattern is already recognizable. And we can very clearly see the spinoglenoid notch, where the suprascapular nerve and the spinoglenoid ligament are located. Above our glenoid, in this segment, due to the position in which we place the probe, we can evaluate the infraspinatus muscle with its normal muscle pattern and its large intramuscular tendon, which is heading, look, towards the lateral side, towards the insertion area at its footprint. Basically a drawing where we similarly write down the findings, ultrasound, so that we can later understand it dynamically. So in the long axis of the infraspinatus, we locate our spine, below the spine. Our probe is placed here, and this is the first image we are going to obtain, where clearly then the number with the infraspinatus tendon inserting at its footprint. We need to know the size of the footprint, we need to know the characteristics of each part, the muscle pattern, the intramuscular tendon pattern, cartilage, the humeral head, the entire extent of the footprint. Look at how perfectly flat it appears. We move more medially and evaluate the entire joint from the posterior side. The first thing we would identify is our glenoid, sound reading. So now we know that here in the spinoglenoid fossa, there is a honeycomb. We already know how to read it, a honeycomb or a mulberry, whatever you want to call it. That's the suprascapular nerve, the spinoglenoid ligament. And there are also structures here like blood vessels. In this position, basically we will then evaluate the infraspinatus and the teres minor. Remember that each of these footprints must be studied in order to document pathology and to know their general size and morphology characteristics. Basically, we are going to locate the teres minor after having evaluated the infraspinatus in the same position where we just assessed this entire recognizable segment, the glenoid, the labrum, the articular capsule, and in our anatomical axis, we are basically going to identify them in the long axis. We are going to emphasize position 3 with our probe in the long axis relative to the infraspinatus. We are going to get this image where you can distinguish the glenoid and the humerus, which are the first two structures. But we can also see the labrum, the entire tendon along its path, from intramuscular to its footprint, infraspinatus. And if we go further down, we will be able to see the teres minor, both in longitudinal and transverse views, or in short and long axis, whichever you prefer to call it. This is the anatomical diagram. Remember that the teres minor is lower than the infraspinatus, but it is also more medial. So if we are going to identify it, we can see it in both axes, in the short and long axis, but mainly in the short axis. The muscular part will give us an image like this, where the teres minor is much more smaller than the infraspinatus, and its intramuscular tendons are also very distinctive. The one from the infraspinatus has a sort of M shape, so to speak. This one is wavy or S-shaped. Basically, this would be the information about the uppermost part and the posterior part of the shoulder, the posterior superior in position 3. So evaluate the infraspinatus and the teres minor. But let's go ahead and continue with the acromioclavicular joint, which I left for this section. However, we can evaluate it in any of the other positions. The acromioclavicular joint is very easy to identify. You reach the edge of the clavicle. Characteristically, it has a slight prominence. And at that step, that's where we're going to place our probe along the axis of the clavicle, in the long axis of the clavicle. And we'll get this image where we can identify the acromion and the clavicle, which is the most important part, then the acoustic window created by our joint with its acromioclavicular meniscus, and you can clearly evaluate the superior acromioclavicular ligaments. If we place our probe more laterally, we'll locate the muscle pattern of the deltoid, and we'll be able to evaluate the supraspinatus along its entire length. And we can do this dynamically, as we're about to show. So this is the image we need to focus on obtaining in order to evaluate and perform interventions. Also the isthmus in the clavicle. Clearly, we dynamically assess the clavicle, the acromioclavicular meniscus, and the superior ligaments. And if we move laterally, as we've already done here, we'll see it dynamically. For example, the thinking sign. If it appears during these abduction maneuvers at the lateral border of the acromioclavicular joint, it then allows us to perform interventions. It's diagnostic for many pathologies, mainly osteoarthritis, but also for dislocations. As in this case, the piano key sign, the acromioclavicular meniscus, the joint capsule, we already know the identifiable patterns of the acromion, and this is basically the image we always want to have. Acromion, clavicle, and acromioclavicular chelate. Remember it so that you can then continue with interventions and pathological diagnosis. That's all for now with the shoulder anatomy segment. We'll continue later in another segment.